Well, my name is Diane Plamping, and I'm an independent consultant who works mostly in the public sector. The sort of work I generally do is what is called systems work, which is the sort of work which can't be fixed by one organization or one part of an organization. So sometimes it's called complex problems, but it usually involves people from several organizations at different level in those organizations trying to make sense of what the problem is and together find solutions. If you were watching me work, I think you might be surprised about the large numbers of people that I and my colleagues work with. We often have up to 100, 150 people in the room. So what you see is them working, not me. My work is often preparatory to working with them, working out processes, tasks for them, so that they really can do work together on real things and come up in real time with their solutions. So you'd see me sometimes inviting questions, sometimes giving instructions for people working round tables, sometimes trying to bring that together in a sort of whole group dialogue. I think the benefit of that, my sort of work, is that people get much more confidence in finding their own solutions. One of the ways we've got into a bit of a hole is thinking that it needs clever outsiders, both to think up the right question, the right problem, or analyze the problem, and outsiders to come up with solutions. And that, frankly, isn't always my experience. And when you try to solve problems in that way, often the solutions don't stick, they're not sustainable. And crucially, people don't learn to solve the next problem. So if it's going really well, we help people come up with solutions to the problems that they articulate with each other. That's often not the first way they describe it, but as they work together, they find something they have in common to work on. And then in doing it, we give them an experience of how you solve problems in this way so they could do the next lot without us. I'm employed with colleagues, usually by people who have seriously tried to deal with problems before. And so they're people who know that solving the sort of problems we're talking about, which usually need partnerships, are not easy to solve, but they haven't given up. And they're interested in the sorts of techniques that we bring which allow them to re-engage with things called partnerships. I suppose if you were to ask me what I was really passionate about, it's why is it so obvious to people that working in partnership is necessary and a good idea, and why is it so hard to do? And so what we're often working with people on is that, not the hearts and minds, they know that they need to work together differently to get things to happen, but they have some confidence in the sorts of methods that we use might this time make a difference. When we work with people for whom this isn't the first time they've thought about this problem, and probably not the first time they've met some of these people, the sorts of things they learn of, first of all, that actually there are more people than they could have possibly imagined who are interested in this. And sometimes that terrifies them to begin with, until they learn how to work with that sort of diversity. But I think one of the things they learn is that they know much less than they thought about everything that goes into fixing this sort of problem or finding a solution. They tend to have worked very hard in the past to come up with an answer from their perspective. And they usually then try to persuade everybody else. So it's quite unusual for them to have to go back and really listen to other people. Not to lose direction, but to understand that if you're going to get a picture of the whole, you have to understand a lot more about how everybody else sees it. And I think, this is often called strategy work, and people often think strategy is about thinking into the future and having a vision. And we don't normally find people are short on that. What they're really stuck on is knowing how it really, 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 really works now. And we slow them up. We make them really try to understand what all the people who are part of this system really do, without trying to think about what they should be doing until quite a lot later. If I had to try and summarize the co-producing project for East Midlands, I'd say that it was two sorts of things. The PCTs have a particular responsibility in their system to define direction and strategy and shape the way services are planned at that level. And so there is something about engaging people, helping people co-produce appropriate strategies for their populations. So that's at one level. There's a whole other level, which is even if you knew about the direction of travel strategically, there are lots of different people, different publics involved in actually providing the service. Some of them are professional providers, but actually in terms of many of the things that the health service does now, like it's helping people live with long-term conditions. So patients themselves are active rather than just done to. So there's another level which is about designing services where professional helpers and the people themselves design effective services. So I think there's those two main interventions levels. But then there are several elements of work which are meant to go towards that. There's one element which is around working with the boards of these organizations to say, what do you think you want to do in terms of designing services and how you want to do it? So introducing them to co-producing. There's a whole regional, a whole SHA network bringing people across from many PCTs together saying, what do you know about co-production, making these services with other people or designing these services with other people. And then there are specific projects. These are going to happen in just 2 of the PCTs in the first instance. And Martin Bontoff's team is leading on that, to actually really take some real services provided by some real people to other real people and co-design something that's better. And in that process, the SHA hopes it's going to get some way of understanding how that happens, and therefore how it could happen in other PCTs who are not the 2 pilot sites. And there's a belief that in order for this to work well, that the doctors particularly have to be able to engage with their patients in a way that enables this sort of co-production, whereas traditionally they've probably tended to take care of people rather than work with people. So there's a special element about working with doctors to help them more able to engage in co-production. And I think this word co-production in some ways is very self-evident, but if you think that most services should be co-produced between doctors and their patients, then that needs doing well, and that has implications for how you do it. But if that's the way the work gets done, the organizations that are responsible for managing these people have to manage in a different way, and the organizations that are responsible for planning have to plan in a different way if the business is co-production. And I don't think that's easy at all. There are 2 big problems really in organizations as big as the NHS, is that most organizational structures are a way of dissipating responsibility. You can always blame them. They won't let me do it, or they don't give me enough money. So there's always a problem about responsibility in big organizations. And then there's a specific problem around what is the right sort of responsibility to take if you're treating someone who's sick. Because traditionally that would have been the language people use is talking about being a good complainant. In the past, a good patient was someone who was able to tell a good story about what was wrong. So the doctor could take that information away, process it inside their head or whatever machine they were using, and come back with an answer. And that wasn't a co-production model. Much more now in modern medicine, people are seeing that sort of partnership is necessary to get to a good solution, particularly if you're living with a condition rather than something that happens to you when you're anesthetized and the surgeon does it to you. But they're both very big cultural cultural patterns, really, that we would probably want to change.